Good evening, everyone, and welcome to tonight's webinar on all things telehealth, SA&GP update. Firstly, I would like to introduce myself. My name is Angelica and I work for the SA College. I would like to also acknowledge the traditional landowners of the respective lands of which we are meeting today and pay my respects to elders past and present. I'd like to acknowledge any Aboriginal and Torres Strait Islander people present. Tonight's webinar is eligible for 2 CPD points, which can be self-recorded. Self-recording is a quick and simple and easy way, and the relevant form can be found on the RACGP CPD dashboard. Simply log in, go to My CPD dashboard, then quick log. If you have any issues doing this, please contact any of the RACGP officers with support for uploading this. Tonight, we encourage you to submit your questions in the Q&A box. We will have Emily Kirkpatrick, who will also be monitoring the Q&As, and we will try and answer these as we go. Tonight, our presenters are Dr. Emily Kirkpatrick, Deputy Chair, RACGP SA&NT, and SA Health COVID-19 GP Liaison. Dr. Danny Byrne from SA Health COVID-19 GP Liaison. Dr. Alvin Chua, RACGP SA&NT Council Member, and Dr. Nick Tellis, GP Owner, Partridge GP. I'd like to now hand you over to Emily, who can start us off.
Wonderful, thank you so much. So we're really excited to be here tonight and to have both Alvin and Nick with us as well, just to hear around all the expertise of what everyone's up to. And then in the room here at the RACGP, we've got Angelica, who's just introduced us here, and Dr. Danny Byrne sitting next to me as well.
Good evening, everybody.
And we've got Alvin and Nick who are calling in remotely. It was only appropriate we had some remote presenters given we're talking about telehealth and telemedicine. So we'll just let Alvin and Nick say hello to everyone.
Good evening, everyone. It's Alvin here.
Evening all, Nick Tellis.
And so as you just heard as well, we've talked a little bit about CPD because all these webinars we've been doing, it'd be great to be able to get some CPD. So thank you for sharing that. That had come through on one of our Adelaide PHN webinars around CPD and wanting to get some points for that. So tonight we're going to go through and discuss the role of telehealth consent process, the new MBS item numbers and a bit of a discussion around that, a bit about telehealth and how to combine that with face-to-face consults, and then about undertaking paperwork while working remotely. And both Alvin and Nick are going to talk through their examples in their practices, a bit about e-prescribing legislation, and then we'll move on to about GP training and how that works whilst working remotely and some tips and tricks. So please ask us any questions as we're going through in the Q&A, and we'll try and address those as we're going because we don't want to have hundreds of questions left over at the end. We don't like it when we miss your questions. And we have got some that have been sent to us via email, and we will address those as we're going. So thank you so much for providing those beforehand. So we'll start going through the presentation now, and just want to mention firstly around the RACGP guide for providing telephone and video consultations in GP. So some of you may or may not have seen this. It came out last week from the RACGP. It's quite a useful handout in terms of going through some of the basics and just a little bit about the consent process as well. And we'll talk through elements about that as well this evening. So we'll hand over to Nick. This is one of Nick's great slides.
Okay, so here's, you may all be familiar with this. It's Keep It Simple Super GPs. So this is a stressful time. Many of us haven't done or experienced anything like this before. And so much like a resus, everything must be really simple, just ABC type simple. And I think, have we got the next slide? Oh, still stuck on KISS. Here we go. So in my practice, we decided to stick with some basics. And the first one was be safe. we can't help anyone, we can't serve our patients if we're doing things that are fundamentally unsafe. And so while community transmission was uncertain, we pivoted to 100% telehealth early with rare face-to-face follow-up. And we thought that was a sustainable system for 6 to 8 weeks while we got our stuff together in regard to PPE and some appropriate workflows. That allowed us that time. The next thing is to do good work. We're still GPs. We still need to be providing a quality medical service to our valued patients. We need to do the best that we can. That's not the best full stop, because as you all know, the best can be the enemy of the good. And then it has to be sustainable. We're normally a private billing practice. However, with the bulk billing telehealth item numbers, we just decided to go to bulk billing, and that entails a slightly different model of care, going from our 15 and 30-minute appointments to a 10-minute appointment model. And again, being sustainable and trying to keep it simple, we just stuck with the phone. Everyone's got a phone, everyone knows how to use it, so that's what we did. So yeah, next slide.
Yeah, so this is something that we put in here was around the different methods that exist. And I know both Alvin and Nick, you're doing different things at your practices in terms of telemedicine versus telephone consultations. And people say, what's the difference between the two? Well, in fact, they're quite different, and the MBS has made them quite different in that telemedicine is using video consultations. Telephone consultations are different and have those different MBS item numbers associated with them. And the consent process is really important to make sure that you're quite clear about that. So I'll let Alvin talk through the differences that that he's had with this in terms of the consent and telephone consults. What have you been up to in this space, Alvin, at your clinic?
We've initially started mainly doing telephone consults only because it's simple, it's easy to use, and pretty much everyone and anyone can use a telephone. There were a few instances where we relented and with patients asking about rashes and whatnot, and I did do my first FaceTime consult, which I got burnt on fairly badly.
Do tell us, Alvin, what happened there?
Yeah, this is true story. FaceTime consult, reason for consult, rash. So rang the patient and switched to FaceTime, and he's a newlywed, and the first question was, where's the rash? And without even any delay, the next minute I was getting an unsolicited picture of a penis on the screen. And it kind of burnt me. And it was a very quick scramble to turn off the video function on my phone because it's what had been seen cannot be unseen, I guess. The main thing is, I guess, is that the bulk of my consults thus far and the bulk of the consults at the clinic have been via telephone. We have 32 voice over IP lines coming in, and I must say, even with our 32 lines, we've run out of lines to use. So we've actually obtained a couple of SIM cards from Telstra and used them for doctors to make phone calls on, partly because as doctors, we probably don't want our phone numbers appearing on patient screens for them to ring you direct. And whilst it's easy enough to hide your phone number, it's probably much easier to just get a phone that is not answered by anyone at the best of times. So we've managed to get that done. The other issue I've had with video conferencing is that no matter what and no matter how you do it, you cannot hide your caller identity. So I guess the fear is that I didn't want to be FaceTimed at 11 o'clock at night with a patient requesting a consult just out of the blue, and when I was not really ready for it whilst in bed, for example. I guess the most important thing with whether you do telephone consults or video consults is that you need to document consent. And a few little tricks around it. I usually have just some auto text created for myself, so it reminds me to say consent obtained, patient aware, this is a telephone consult and there are limitations to that. So that's my way of doing things. And it's also probably fairly important to realized that there's a difference between item numbers for telephone versus video consultations.
And I mean, one of the things that's been coming through on the chat Q&A already is around the different types of platforms to use for telehealth consults, and we will talk about that soon, because it's been quite interesting seeing all the different players all coming together and seeing how this all works. And we will talk a bit about CoView as well, and what the PHN is offering and how that all links together as well. But we'll go and talk about that now. So Alvin, what's your setup in your practice in terms of what you're using at the moment?
Basically, the handful of video consults that I've used FaceTime for Apple operated devices, and the rest of them have been done via WhatsApp, and also there was one Skype consult. I've avoided Zoom, not because of anything else, but because I just don't particularly like Zoom. And I guess in the last week or so, there's been a bit of a fear raised about the lack of encryption with using Zoom.
Yeah, and so and then CoView is the other one as well that we've had a few comments around, and so that is one where you then don't have to display, you know, a mobile phone number as part of that. And so Adelaide PHN and Country SA PHN are offering where you can contact them and you have a trial of using the Health Direct, which is through CoView, or you can directly contact CoView and get a trial with them as well. So, and that from our feedback has been fantastic. Danny might have a few words about that as well.
Just some research I did into CoView end of last year, not predicting COVID was coming, of course, but it's a CSIRO developed product. It's a spin-off. So it's really quite comes from a high pedigree, I suppose. Definitely very secure as far as the encryption goes. You can share your clinical software screen with a patient, much like you might do in a face-to-face consult. They are offering a free 1-month trial right now. The other thing about it, I don't understand the technology that well, but it works just incredibly well over tiny bandwidth. You don't need software, it just works with the internet browser. So quite a nifty little product, to be honest. I don't own shares in the company, but from what there's a plethora of products out there. It's quite interesting. I might make the comment now that the government never makes a list of anything. It's like chronic disease items. You know, there is no list of what is a chronic disease. They just say, here's a chronic disease item. So if you ring them up and say, is this a chronic disease or is this a chronic disease? They'll go, nothing to do with me, you're the doctor. It's the same with what is a allowable software or product to use for video conferencing. They say, it should be this, it should be secure, it should be encrypted, it should be this, it should be that, but then there's no list anywhere. So they're leaving it up to you as a professional, I suppose.
And we've had a few comments around GP consults as well as the other provider. And certainly it's been quite a competitive market. So we know that these trial periods where they're suggesting you can get a trial, we don't know how long that's going to last for. They've said the period of COVID for some organisations and the ones through the PHN. So it's just really a matter of well, how long are we going to be using telehealth for? How long will these items be in existence for regarding COVID? But certainly we're hearing really positive things coming through from all of these providers, and it just depends on what you're comfortable using and what your patients are also comfortable using, and whether they have the ability to create accounts or they want to use GP consults or use CoView. So certainly lots and lots of options to think about, and we're very happy to take feedback on board. If someone wanted to send us anything they thought was useful around this, we're happy to then redirect someone to you if you're using a particular platform and you'd like to know more about that. Very happy to link you all in, but lots of options. The advice really from the Department of Health has been to reconsider using free platforms because of the concerns around privacy and security. But that's something we need more information on, and certainly we are hearing things coming through from Department of Health around that.
I'd say don't let perfect be the enemy of the good.
And certainly SA Health has been using telehealth for some period of time, but it's been a super clunky process. Is that right, Danny?
Yeah, so they've got a very strict rules about the Cisco products. They have to be used, and the device at either end has to be an SA Health computer or laptop. So it's not being done into the patient's home. The patient has to go to a rural hospital or a rural health centre owned by SA Health. So quite strict and clunky. It obviously worked fine because it was very secure, and they've got great digital networks, but had none of the flexibility that we're experiencing right now. And quite interestingly, about 4 weeks ago, Chris McGowan, the CEO of SA Health, just signed a directive that anything goes. So overnight, the hospital doctors are now using FaceTime, Zoom, all the products in the world, and not using this secure digital network because it's just too locked down. So it's quite interesting in the time of crisis. Whatever works is fine.
Yeah. And we don't quite know what the fees will be for all of these platforms as well. That's come through around questions. I mean, it's really going to depend on how many people are in your practice and what you're using it for. So I would suggest just contacting them for advice.
I'm old enough to be around to know that medical director and MIMS prescribing were given away for free, and you had ads popping up. Then you had to, if you paid a little bit of money, you didn't get ads, and then the government banned the ads anyway. And now we're paying thousands of dollars annual subscription fees for these products that we can't live without. And I imagine the market will do the similar thing with Telehealth. 3 or 4 products will sort of rise to the top, and you get what you pay for, don't you, in this world?
And yes, but certainly very happy to be emailed through. If anyone would like to be linked in with someone, we can certainly provide the linkages for you. We can't actively say what provider to go with, no. but we're very happy to link you with others for more information, because this is a bit of an unknown area. And in terms of consulting overseas patients, that's come through as a question. I'm not aware of any issues with consulting overseas patients using this technology, but obviously you can't be using MBS item numbers for patients for that if they're not don't have Medicare. In terms of the bulk billing requirement, this has been quite topical, of course, online as well, with non-GP specialists, of course, having different rules and regulations around billing. And just wanted to emphasise that was from the 6th of April around the bulk billing requirements. I don't know, Nick or Alvin, whether you want to talk about how this is working in your practices, or what you're up to, or what you've decided to do in terms of bulk billing requirement.
I'm happy to speak about that. In general, if you look at the restrictions that they put in place with regards to compulsory bulk billing, I dare say for the amount of work involved for what should be a fairly quick consult at bulk billing rates, we've elected as a practice to just bulk bill it, because the saga involved with trying to work out, are you eligible or are you not eligible? Are you a person with chronic disease, or you're a person without chronic disease, and let alone the healthcare card and children. And we've just decided as a clinic to just adopt universal bulk billing for, even though we are a mixed billing practice, we've decided to adopt universal bulk billing for telehealth consultations for the moment.
And how about
I'll carry on, Alvin.
Yep. Go on, Nick.
Look, we had very similar thoughts to Alvin in our practice. We are a mixed and predominantly private billing practice normally, with 15 and 30-minute appointments. However, the complexity of the government's rules for bulk billing made that unworkable in practice. And I think it was unworkable for our GPs. And one group that we can't forget here is our fantastic admin staff. Our telephone call volume went up 300% when we moved to telehealth, telephones, and all of this pivot to telehealth. And getting the administrative staff to have long conversations with patients, with the end point being that the remuneration was 1/3 of what we would get normally, was completely unworkable from a business and administrative perspective.
And that's quite interesting, isn't it, really, just in trying to differentiate who's at risk of COVID and how long these requirements will last for. We'll talk a little bit next about the difference in terms of the rebates. We know that the rebates, don't differ in terms of whether you do telemedicine or telehealth consultations. It's the same rebate. amount. And we know that this is an evolving area, these item numbers, and particularly we were just discussing before around after hours numbers. And I think, Alvin, you were talking about that hasn't gone through yet. Is that right?
I think this came to a head on the weekend just gone with the Easter public holidays. A lot of GPs were expressing on online forums, including GPs Down Under, about the lack of equivalent item numbers to the 5020, 5040, etc. item numbers, i.e. the insociable after hours item numbers have not been thought of with the telehealth items. The out of social hours telehealth item numbers are available though.
Right.
And in terms of the nursing home visits, we've had a few questions come through to us at SA Health around nursing home visits and still not having the full suite of item numbers to claim through telehealth as well. We know that certainly the item numbers around GPMPs or chronic disease item numbers are there now for nursing home and for non-residential aged care facilities in your general practices. But we haven't seen that in health assessments either, in terms of the 45-year-old health assessments, just in that in the older age group health assessments, not yet either, have we? No. It's just been Aboriginal and Torres Strait Islander ones.
Yep.
So that's been, hopefully we'll see some change in that. And we have been reassured. We have been emailing, we've been quite lucky, we've been able to email Michael Kidd a few of our questions and get quite quick responses. Thanks, Danny, for your college connections there, and get some answers there. So we're very happy to try and provide some information out.
I might give a couple of examples with my role in SA Health and just liaising between the GPs out there and Canberra. So the first one was they announced an obstetric antenatal item number, but that was for obstetrician specialists only. And within 4 hours of a rural GP in Kadina, Graham, emailing me, flicked it off to Michael Kidd, and later that afternoon had been opened up to all GP obstetricians, midwives, and specialist obstetricians. It was just, I think it was a simple oversight, but you know, when things are rushed and things aren't thought through, it's been a crazy 4 weeks, you can all imagine. And then when we had the ruling that you know about an immunocompromised patient could be treated, but an immunocompromised GP, age, or you know, GP's breast cancer or on immunosuppressant medication, Crohn's, rheumatoid, all sorts, diabetes, type 1. And to get that changed so that those GPs could work from home and access telehealth was quite a highlight for me. I had some very emotional phone calls from some of you out there. It was fantastic that we were able to get that changed. And I don't think it was malice on the part of Canberra Medicare. I just think they just never thought these things through. Yeah.
And it's so complex to know what to do with aged care billing as well. We've had a few questions come through around that in the chat box, in terms of how do you bill those. And the advice that when we then wrote as well to Department of Health around that was that to use the existing numbers that exist, which is less, unfortunately, at the current rebate, in terms of if you're using the existing 23 type item numbers for telehealth consultations, that will be less. And we hope that will change soon once they go through and update all of their items, which has taken so much time, unfortunately, because there's so many hundreds of item numbers.
Well, it's a bit tricky, isn't it? Because nursing home item numbers have a component built in for the travel to the nursing home. And if you're not doing the travel, you know, I can, you know, Medicare aren't stupid either. They think a few things through as well.
Can I speak to this one, Danny?
Yeah.
Look, one of the major issues with nursing home work is the frank disorganisation of it. You've got to go there, you've got to find the patient, find the room, find the notes, find the nurse, find this, find that. Yep. There's, I think, you know, other GPs have talked about this at length. Now, telehealth does, and the telephone actually cuts through a lot of that. And again, you've got to cut your clothes to suit your cloth. All of the unpaid phone calls that we have all made to every nursing home in Australia is now paid work. So yes, your 9001, your travel time, some of the CMA item numbers, some of the enhanced primary care item numbers are offline for the moment. This is a short-term thing. In the meantime, cut your clothes to suit your cloth, make short, sharp, shiny, focused phone calls to nursing homes, and get patients the valuable care they deserve from specialist GPs rather than after hours locum services.
Yep, I couldn't agree more. I mean, one of the interesting things about this whole telehealth saga is that all of a sudden, oh my God, I'm getting paid for all these phone calls they just used to make for free anyway, day after day after day.
But what we will mention with that is that we have, we get, hundreds of emails a day. Like, I think our email numbers have gone down a little bit now that everyone's sort of getting more into the swing of things with COVID. But, cold calling patients and going through a list of patients and billing them for that is sort of not really the intention of telehealth item numbers. And we are, we have been contacted to ask, is that something that we can do? And certainly calling a patient, scheduling in an appointment with a set problem and then discussing that problem as per the item description is acceptable, but just calling a patient up without an appointment doesn't meet the current description. So just keeping that in mind.
Looking at these item numbers and thinking, how can I be creative and how can I manipulate them or so forth is not really what I think a good GP would be thinking about. Got more important things to think about, like good patient care.
And also the bulk billing incentive payments being doubled as well, just to mention that as well, that's in effect till the 30th of September at this stage.
Yep. Can make one point here though, that, and SA&Health are very aware of this, is that pathology testing and attendances to ED are both down around 30 to 40%. Now,
a 9-minute wait at the RA yesterday.
GT consult.
Which is,
I mean, it is fantastic as far as COVID goes, and there's 400 empty beds in the public hospital system. They've cleared everyone out. People have been sitting in the hospital bed for 9 months waiting for a nursing home. All of a sudden, in 3 days, they get one. So it's quite incredible. So all the planning, don't waste a crisis. But people's breast cancers and bowel cancers and ischemic heart disease, their plaques in their coronary arteries, they're still there. They're still growing right now. So there is a concern that post-COVID, we're going to have a lot of late-stage diagnoses. A breast cancer that's already metastasized, or a bowel cancer that's level 3 instead of stage 1 or something. So still be aware that patients need to be seen and having their HbA1cs measured and electrolytes checked and all this sort of thing.
And Judith's posted a really good question on the Q&A as well around rural practices and how are they going in terms of seeing their patients, because usually that's the main point of call. People go get their bloods taken at the GP, their INRs, dressings, all of those things that are sometimes not performed in clinics during this time period. And we've got the flu injections through town halls that we talked about a couple of weeks ago on one of the webinars. But I mean, it's just, we'd love to hear feedback about how you're coping in this time and ways that we can sort of spread things that you're doing that are working well, or things you'd like help with from other GPs as well. We've just put up the telehealth medicine numbers here just so you can see these are the ones here for telemedicine, and then the ones for telehealth as well. So they're the ones that the telephone consultations, and you can see exactly identical rebates for both of those. And it's any one of the following. It's taking a history, investigating management plans, and providing preventative healthcare. It's any of those that are clinically relevant.
Don't have to do A, B, C, and D.
Yes.
No.
Because we had some feedback around, do you need to complete the consult around the telephone in terms of if someone rings up, and this was actually something that came through in one of our in the email questions. If someone comes and they call up in the morning and then you see them in the afternoon, how does that work with billing that item number? I don't know if you're happy to talk about that, Alvin.
So you're talking about a telehealth in the morning and then a face-to-face in the afternoon. Yeah.
I guess the question, there was a suggestion that a 3 to 4 hour rule applies, but I really haven't been able to find hard evidence as such. I don't think that it'd be unreasonable for you to perform a telehealth consultation at say 9 a.m. and organize for a face-to-face later in the afternoon if required for the patient, say at 2 or 3 p.m. I can't see why that would be frowned upon. However, if you organize a telehealth consultation at 9 a.m. and tell them to come in straight away and they're there within the hour, I would have thought that it doesn't pass the pub test of giving a separate telehealth as well as a face-to-face item number. But those are my thoughts. I honestly don't know.
No, I think you make a good point there about the pub test, or what I call the reasonable there's a reasonable GP or your profession, your peers. That's the
Exactly.
term.
If your peers
I could chip in my 2 cents here. I have heard that some people are doing phone consultations with patients in the car park. And then if an examination is required, they meet them at the back door and claim a 91809 and a 23 inside of 5 seconds.
Yeah.
I suspect if I had the video on here and we saw the combined GPs' faces,
Yep.
get our answer on whether that was acceptable conduct or not.
Yeah, that's just so far out of left field that I couldn't even have thought to make that up. The fact that you can think to even make that up makes me sad.
It's just like the claiming of taxation. It's only a problem if you get caught. You can claim.
Yeah. That's true. You got to be able to sleep at night, though, don't you, guys?
Exactly.
Yeah.
And then we see AusDoc are putting out different things around, top health telehealth company says it's safe from APRA threat. And I mean, we've heard lots. I mean, you've probably heard of lots as well, Alvin and Nick. With both being co-administrators of GPD, you're around issues with different online providers now offering telehealth consultations without the ability for face-to-face consults. I don't know what your thoughts are on this, or if you've heard of any stories around this area.
Emily, I think as far as I'm concerned, and I'm quite happy for this to go out live, AusDoc is absolute rabble-rousing. It is not a particularly edifying read, and I think most GPs, if it weren't glossy, would substitute it for toilet paper. And that would probably be its best and highest use.
Yeah. Well,
as far as I'm concerned, if any,
we'll just say that's your opinion.
Yes, it is. But seriously though, I do think if any fellowed GP feels that the valuable service they provide to their patients can be easily substituted by some random cold calling their patients, then I suggest that's probably misinformed.
Yep. I think when these threats are around us all the time, and pharmacy is a threat all the time. You provide good quality care to your patients that you know, and continuity of care, and you'll win out every time. I'm 100% convinced of that. So yeah, sure, be aware that they're out there, but you beat them at their own game basically by providing a better service.
And we know about the PIP as well in terms of the requirement as well to offer face-to-face if you do want to see that that extra payment coming through, which is probably, given we've heard of low numbers across general practice currently in terms of what impact COVID is happening, we've got to be thinking of other ways to ensure that we can have viable practices.
It's quite interesting because the minute, a lot of us wanted that must be a patient that you've seen within 12 months or a regular patient. First it started off of the individual GP, then it became the practice, and now they've dropped that altogether because it's unworkable in so many scenarios. University students don't have a regular GP, so forth. So and rural patients, and but the minute they drop that for very good reasons, then these entrepreneurial doctors popped up like mushrooms.
Challenging. Alvin's put together some fantastic slides just to go through his practice in terms of what he's up to, and I'll hand over to you, Alvin.
No problems. The following slides are really a little guide as to how you can actually do your telehealth consult from home and print scripts and have it sent in a bulk to print at work, so you don't actually have to go in, for those of you who live away from the practice, for example. And the first slide here, basically, sorry if anyone's using Mac, this is more PC enabled, and this is a screenshot of your control panel going to devices and printers. And next screen, please, Angelica. And on there, I've selected my default printer as the Microsoft Print to PDF printer. And by doing that, when I print a script, it prints to a PDF file. So Angelica, as you can see, I named the file test for the patient's name, for example, and the file is saved. And on the next screen, you can see this is a ZNet generated script with the ERXQR number. And if you lower down, there's actually a Met objects item number. So opening the Microsoft, sorry, next screen, Angelica, opening the fill and sign screen, you can actually put in your signature file in there. And if you go to the next screen, Angelica, select your signature. And in my case, I've actually scanned my signature into there, or you can actually use a write pad and sign your signature as an image. And that way, if you look at the next screen, you can actually see that I've actually dragged my signature and put it on the script. And if you save, say, 12 scripts, you can actually email it to your administrative staff the next day to get them to print en masse, or alternatively, just ring up work and say, is there script paper in the printer in room whatever, and hit the print button, and you've got a script printed that's legit. As far as I know, I'm not certain as to whether the electronic signature version is universally acceptable yet. I'd hazard to say that lawyers are using it for consents for signatures, and I presume they'd accept it for us as well. So if you go to the next slide, this way I've saved it and it's in there, and I can actually email that file. Hopefully the slides make some sense, and if not, I'm happy to answer questions about it.
And what we will do is we'll talk a little bit more about prescribing as well and the current legislation around that as well. But I think that's an excellent way to demonstrate how, if you're working from home and you're, you basically you want to be able to send your script still electronically and still retain that paper copy, which then the pharmacy can then be delivered to the pharmacy. And Alvin, you've got a great system happening in terms of great relationships with your local pharmacies as well. Is that right?
Yes, we have 5 pharmacies in close vicinity to our clinics, and we all 5 have agreed to perform weekly pickups from our clinics. So we have a system whereby 5 manila folders at the front desk, and patients nominate which chemist they prefer to go to. And for example, Chemist King or Priceline or Terry White or National Pharmacies. And from there, the scripts are actually printed. The patients let the pharmacy know that it's been done, and the pharmacy organizes to come and pick it up once a week. The chemist is happy with it because it saves them sending me $1.10 self-addressed envelopes, and this way it's a win-win for us both. We don't have many patients coming into the building just to pick up 1 or 2 scripts at a time. We just have one representative from the local chemist to pick up, say, perhaps 20 or 30 scripts at a time.
Yeah, and that's really fantastic. A good way to sort of get around that time lag as well. And I mean, this is something you've been doing as well, Alvin, at your clinic.
Yes, we are trying to minimize our face-to-face consultations, mainly to minimize the number of potential vectors in the building and to protect our staff as well as other patients. So if we have done a telehealth consult and deemed that it's necessary for the patient to come in, for example, for a rash, for a skin lesion, for anything else that requires auscultation of the heart or lungs, for example. Once they've screened, I'll give them an appointment time, say at 9:30, and I tell them specifically when you get to the car park, you ring from the car park to let us know that you have arrived. And once we're ready for the patient to enter the building, we ring the patient on their mobile phone. They come in and they're ushered straight into our consulting room. And this limits the potential time that they're sitting in the waiting room for. And more importantly too, we also can do most of the history taking by phone if you prefer, but we do not charge both a telehealth item number as well as a face-to-face item number. Haven't been that bold yet.
And we've had a lot of questions coming through, Alvin, around your scripts as well, and how you do the fill and sign command on the save to PDF option as well has been posted as a question. So if you're happy to answer that, I'm sure you will be. But certainly it is a very confusing time with prescribing, and what we'll do is just go through a little bit about where that's up to as well. So Danny and I have been having regular meetings with the SA Health, with the chief pharmacist here in South Australia, and also with Angela, who puts forward the legislation and communication as the legal advisor to the chief pharmacist. And this has been really important because it's been very difficult getting everyone on the same page in terms of this new legislation and interpreting it. And we've had feedback coming back to us from multiple GPs around, I'm faxing it, I'm doing this, but the pharmacy has said we're not going to accept this. And unfortunately, we're just not quite there yet with getting good communication out to everyone in this space. And when we do, we will certainly be communicating that through.
Because what's needed is a fact sheet that spells it out for the GPs and for the pharmacists, so everyone's on the same page.
And so we will just go over a little bit about the legislation now. So there's three different things really happening, and I think there's a slide, maybe it might be the next slide coming up. No, not yet, but that's all right. When we get to that slide, then I'll go through that. Right. I'll let Nick talk through this slide.
So this is some pictures of the various setups that we've got, the tools of the trade. We are set up so that we can work from the practice itself, or all of the doctors can work from home with their own setups. We all have remote access, which we had anyway for checking of results out of hours. All of the doctors have a printer, and we've given everyone a little care package of script paper, pathology paper, and radiology paper.
Oh, that's so generous.
Yeah. Oh, yeah, it was tough, but we got out there. The other thing that we've managed to do is we run our practice phones on a VoIP system, and we have cloned the VoIP system, which is 3CX, onto each doctor's mobile phone, so that it can call from an app on the phone, and the number that will come up is the practice's number, not the doctor's number. So essentially, we've all got remote dial into best practice. We can all print scripts, pathology and radiology out at home. We've also used Office Lens to scan signed documents and email that through our secure email system to our reception or to some of our local pharmacists. And that seems to have worked reasonably well so far. It also, again, I think underlines the issue that keep it simple. Phone is simple. Yes, you can use Zoom. Yes, you can use CoView. Yes, you can use all of these things. But, you know, in this uncertain time, we preferred to go with the certainty of phone.
Yep.
And following on from that, I like to think that when you have to do something more than once, you should set up a system for it. So the MBS has quite clear written rules, and you can reflect those for compliance purposes in the form of an autofill, which you can do in all the software packages that I've used, which is ZMed Best Practice Medical Director and some other horrible software that I've consigned to the dustbin of my memory.
Yep.
But you put an autofill in, and what this does is it works from a compliance point of view that you've done that, and it works as a memory aid for you as well. And part of this is when the patient is claiming their Medicare rebate, then more often than not, that's going to be 23 or 91809 rather than a 3 or whatever the telehealth version of that is, because you are turning your mind to a Medicare rebatable service, a valuable medical service for your patient. You can take this time to update the notes. Every time we do accreditation on an audit, we see that there are patients with no past history, no allergies, PRN medications haven't fallen off the medical record. This is an opportunity to tidy up those medical records and meet the RACGP's clinical indicators for excellence, both for accreditation and for your personal excellent medical service.
Here. Well done.
And just thought I'd mention this around screening patients over the phone. You've probably all seen, and you probably already have your own algorithms or processes that you had for administrative staff to go through screening over the phone. And just wanted to mention that GPSA have a really useful guide online as well regarding this and a few other useful things. So you can check that out on their website as well. And oh, what a cute photo.
Who's this?
That's my son and heir there.
right.
I try and get him into every PowerPoint that I ever do. But the take home from this is paperwork, as Danny's alluded to. Thankfully, the virus, first thing it seems to have killed is paperwork. And thankfully, common sense is making a comeback. So the first trick with paperwork is eliminate it. If it does not need to be done, or if it's being done for somebody else's benefit, get rid of it. The next thing is email just works a hell of a lot better than fax. Now, if we have to use fax, so be it. If you've got access to fax in the practice, or if you've got one of the e-fax solutions, that's great. But email, we all know it has privacy issues, but again, sometimes the best is the enemy of the good.
Yeah.
Again, I'd remind everyone, your admin staff are doing it bloody hard at the moment. They are answering more calls, they are doing more work, they are well out of their comfort zones. And the last thing they need is to be hammered over the phone by patients who are concerned and uncertain, and then turn around and see a pile of, frankly, unnecessary paperwork. So that's where we get to what Alvin has mentioned with this idea of batching up stuff in manila folders or some other way and dealing with it regularly every week rather than trying to task switch all the time, which is difficult for us GPs and super difficult for admin.
And you can see this picture just there on the other side there is thanks to Dr. Pete Richforth, who sent this through to us to say, well, what's happening with the e-pharmacy? They're building up at the Bridge Clinic.
Yeah.
So we'll talk a little bit about that as well now around e-prescribing. So it's a bit hard to read of this. We're very happy to send this out as well because we can provide the links to you. But you can see there in the middle was the communique that came out from the Office of the Chief Pharmacist. So this was around the new legislation that was passed last Thursday. And that's the legislation you've probably heard a bit about from Canberra. Every state has different legislation, and we've all passed those within the states now. And it's just a matter of getting that information out to the pharmacists, out to the GPs around how this works. So e-prescribing is whereby you're keeping the script for 2 years. So that's retaining a copy of the script for 2 years. You can send the script via email. You can do what you like with the script to get it to the pharmacy, but you need to be keeping that script for 2 years. And you can use the signature, but it's still, that Alvin talked about, but it's still actually sending that and retaining the paper copy. So there is a difference, and we had this discussion today. You had this discussion today, Danny, around electronic signatures and encrypting the script.
Yeah, so in, I thought it was coming in 2 months. Everything's been coming in 2 months, but May, which is actually only a couple of weeks away now. So time's just been going so fast. So e-prescribing, genuine e-prescribing is where your electronic signature is not going to be a picture of your lovely handwriting. It's embedded into a token or a barcode that sits inside the prescription that's magically sent off into the cloud, and the pharmacist and the patient meet up somewhere in Australia, and it downloads magically. I don't understand how the technology of it, but your electronic signature will be in that. That is different to what Alvin just showed us of inserting a picture of his prescription onto a piece of paper. That's not what electronic signature means in the electronic IT world.
And then
there are QR codes on the scripts.
Yeah. No, a lot of you have probably been seeing those barcodes and QR codes on the script, and that's sort of the building blocks of what e-prescribing is going to be, which is all set to go and is legislated for. It's just the technology side of it has to be tidied up. So fast tracking it because of the COVID to May was part of the the government's money being spent instead of it happening sometime next year, I think.
And then the other thing is fax. So we've talked about fax before in terms of, so fax can still be used, and certainly you can fax your scripts, you can post your scripts, but looking through the legislation, this was actually already in the legislation and it's been uncovered and has been now distributed out to GPs. Maybe we need to read this more often.
Well, this is funny because this is existing legislation that's been around for donkey's years, which I never knew about.
No, and so this is basically what the legal advisor to the chief pharmacist dug up for us and said, well, you can be doing this already. And we said, oh, really?
No one told us.
So now we've been trying to get this message out, and it is going to be going into a fact sheet. It just hasn't unfortunately gone out because it needs to be signed off by the pharmacy guild and a few pharmacists. But essentially it's that you can endorse the script. So if you write the name of the pharmacy and the address for that single pharmacy, it can be faxed, and there's no need to send the original script or retain the script for that one that's been faxed. It's completely different legislation to the e-prescribing. The e-prescribing legislation that went through last week only applies for telehealth consultations as well. It does not apply for your standard consultations. So we need to have a bit of a look around how that will work. But the e-prescribing that will go through hopefully within the next month or two will apply to all consults. But we're just not quite there yet with our communication.
So I would have thought the easiest thing to do is when you're doing your prescription, one in the morning with food, and then you've got that little box. Well, I'm thinking of best practice down the bottom where you can type in other instructions, but that's where you could write Chemist King, Old Ranella, 253 Main South Road, whatever it is. And as long as that script is then faxed to that specific pharmacy, not to the patient, not emailed to the patient, or it has to go straight to that pharmacy, then that's a legal prescription that doesn't have to be followed up with the original.
And it needs to be on the script itself. It has to be as part of the prescribing details on the actual script. You can't just put it on the cover sheet. That was a question that's just come through.
Yeah. Just out of that, you'll get to know the names and addresses of all your local pharmacies and their fax numbers. I might put a little plug in here for Health Direct. There's a web page called Health Direct, and all of us, our clinics are on it, our fax numbers, phone numbers. But every pharmacy I've looked up on Health Direct, their email address is actually there. So that's a little tip if you need it.
And we thought we'd put a little bit about this. I mean, Nick, you've got a good system happening in your practice, and you have, I don't know whether you want to talk about that at all around how you're going with supervising your registrars.
Well, we've got the next slide coming up, I think, is our registrars.
Yes, there we go. Wonderful.
There we go. So again, I think when you look at these things, you want to start with the end in mind. And GPEX, I think, have very much made the point to us that your registrars are your employees, and you need to spend the same amount of time and wit hiring your registrars as you would any other employee for your practice. So we feel that we've got that system down very well now. We recruited well. We've invested a lot of time in our registrars in onboarding them to our systems. And that way they were able to move to a telehealth model for reasons that they didn't really know anything different. They hadn't got 10 or 20 years of baked on GP experience that they had to sort of unlearn and relearn. So we found, firstly, GPEX have been very, very accommodating. We actually stuck one of the spare practice mobile phones on the wall and used FaceTime aimed at the GP. So the medical educator was able to supervise with a direct supervision rather than dragging the GPEX external supervisor out to our practice. That worked very well. GPEX has GP365, which doesn't need sort of face-to-face interaction with the registrars. We are still consulting from our rooms, just using the phones, so we're always there to be tapped on the shoulder, or virtually tapped on the shoulder, and otherwise we're available by phone 24/7, 365. And we found that we've all got mobile phones. We can all send a text. We can pick up the phone if a bit more colour is required for the conversation. So 95% plus of what we would do to supervise our registrars can be done with social distancing and telehealth.
And I've just put a little bit here around supervising registrars. I think that sounds fantastic what you're doing, Nick, at your practice. Remote supervision has been happening now for some time, particularly in the Northern Territory and also in remote areas with RVTS, particularly been fantastic for registrars in doing remote supervision. So models do already exist. We've already got quite a bit of data around how that can work, and certainly having regular check-ins, having an online system either through Microsoft Teams or a messenger system within your practice can be very helpful to be able to send messages. And we do encourage that you keep in regular contact with your registrars, and saying that you're with registrars that you're able to contact your supervisors. You have their mobile, have a backup supervisor if you can't get through to someone, or a different person that you would contact if you need some help with troubleshooting if you're working in different locations. The other thing I thought I would just mention here is that I'm leading a research project at GPEX this year around electronic learning logs, and seeing how registrars can track their learning in the consultation and then send that directly to their supervisor or medical educator. So we're hoping to get that up and rolling in the next month, so that hopefully will be useful to both supervisors and registrars. And we've adapted this project significantly now to take into account COVID. So yes, very interesting times ahead. Oh, I love a good picture there. I'll let Nick talk to this.
Okay, so I thought I'd wake you all up at the end of this. Sometimes these things, you can sort of go into autopilot. So the reason for this is, as I said, a lot of our doctors and all of our staff, in fact, the whole practice can be working from home. We've got a very decentralised model. And when you're working from home, or when your staff or doctors are working from home, it covers if they need to be in isolation or quarantine, or if they're unwell. It speaks to that safety first perspective. It also leaves us with some free rooms in the practice. And while we still have a physical location, and we still have we still have a practice, and we want a physical practice, probably the second biggest cost for most practices after wages is the rent of their premises. And so the concept of being rent-free, there's certainly some room for practices, if they are feeling the pinch commercially, to renegotiate their rent. And we obviously all have the capability for face-to-face consults. One thing I've found is the three people on this picture, or the three entities on this picture, Donald Trump, Pete Evans, and the Professional Services Review, seem to also live rent-free in many GPs' heads. And so I'd come back to those three principles from the start: to be safe, to do good work, and to be sustainable. And then you never have to worry about Pete Evans, Donald Trump, or the Professional Services Review.
Simple as that.
So we've had so many questions come through, which has been fantastic on the chat, and we've managed to answer just about all of them now, which is wonderful. So over 70 questions. Really just feel free to post any other things, to email us as well, but anything further that Alvin or Nick you'd like to add as well, some tips and tricks.
Can I ask you two guys, because you're at the coalface? I mean, I have to be honest, I'm a bureaucrat now. 4 weeks in SA&NT, haven't seen a patient. Never worked harder in my life, I'll be honest. What do you see happening long term? This is meant to be time limited, COVID specific, but what do you think might really change?
I'll take this one, because Alvin will have a much better take on it than I will, so the wisest person can answer second.
Right.
I think it will be very hard to put the telehealth genie back in the bottle. I think now that a lot of us have realised that many of the things we do in general practice have been done that way because we've followed the funding model.
Yep.
I think patients and doctors and staff enjoy the convenience of remote consulting, and I think it will play a big place beyond the 6 months that it's in place for. One of the doctors on the one of the participants said, look, it's never going to replace face-to-face. And I agree 100% with that. Mm-hmm. But we will have a variety of tools in our toolkit to attend to various situations. I just think telehealth and aged care go hand in glove. I feel a lot of palliative care can be done via telehealth. Mm-hmm. And the curse of unpaid work can be knocked off with telehealth as well. I think this will be a period of great change, and it's a bit scary for a lot of people, doctors, patients and practices, but I think there'll be a lot of opportunity to make things better as a result of this. So I'm fundamentally optimistic.
Yep. Alvin?
Now Alvin will tell the real story.
I'm optimistic about it. It's, as you've quite rightly said, it's a genie that's going to be impossible to put back in the bottle once released. And I suspect that the government will have to wake up to itself and extend it beyond the beyond 30th of September, because once your patients have had an inkling that, hey, this works, this is convenient, and my taxes pay for it as per everything else, they'll expect something for it. The hard part, the one thing that I do worry about is that it's all swell for us to take a bit of a hit in a setting where numbers are low and there is that bulk billing that's available. My biggest fear is that we've trained our patients over the years to accept that healthcare is not free, and they've actually been agreeable to pay for quality service, and suddenly I don't think I'm any worse a GP by doing a bulk bill telehealth consult. I certainly don't dumb down my services by any means, but I also fear that the patients will come to expect and say, hey, you used to do it for free, why am I paying for it now? So that's my fear of the whole situation.
Yep. And this statistic that attendances at ED and pathology tests are down 30-40%. Are you sort of got any thoughts about that, or?
Yeah, well, I think as a practice owner, most of us already have been approached by our tenants, pathology lab tenants, for 50% rent rebates or to that extent, and they're citing that their numbers are down and whatnot. But hey, we're all in it. We're all suffering. The bank certainly, even with the code, I had a massive chat with my bank manager today about all these so-called incentives that are available. And the reality with it is that, hey, the banks are still expecting their pounds of flesh. They might defer the payments for 6 months, but do not be under any illusion. It's a deferment of interest only. You still have to pay it, and at the end of 6 months, they're talking about capitalizing it back. So it's not it's not foolproof. And yes, I see David Dumbs made a comment about you do not have to give them a reduction. I certainly agree with that. They'll try anything, and I'll be the first to say, yes, they can ask for a deduction. Doesn't mean that you have to accept it, and it's a two-way street negotiation.
Yep, for sure.
Gosh,
All right.
so we've gone a little bit over time, but thank you so much. It's just been so wonderful having such a collaborative group and to hear so many things that you're up to as well, Alvin and Nick. Thank you so much for giving up your evening tonight to talk through what you're up to and to provide all your tips and tricks and expertise in the space of telehealth, telemedicine. As usual, we are very happy to be sent emails, and we can redirect those emails to Alvin and Nick as well if you have specific questions as well. Don't inundate us with too many emails. But no, we're very happy to be asked questions. I just want to make one last mention before we finish off, and that was just to say that in the space of all of these changes, and in terms of with COVID and organising pathology drive-through testing services, SA Pathology has changed their rules this evening.
Yes.
And so we just wanted to mention that to you. So there'll be no longer a booking process over the phone for drive-through testing clinics through SA Pathology. It will be through the fax service, and we'll send that out in the morning, those details for that.
So simply you fax in the request form to SA Pathology. As long as it's got the patient's mobile phone number on it, SA Pathology will ring the patient and organise the time and the booking. They've taken your staff and yourselves out of the process, which is...
We've been constantly harassing them, haven't we, Danny, about the wait times. So I just want to feed that to everyone tonight, and we'll send that out in the morning as well.
Yep. Excellent.
But thank you so much to RACGP for hosting tonight and for having us here, and for us all to be able to share what's been happening in this space. So thank you.
No worries. And thank you, Emily and Danny, and obviously Nick and Alvin as well. Just letting you know, this webinar has been recorded and will be placed on the RACGP website. So if you do want to revisit it, you're more welcome to.
Yes,
Yeah.
and the Q&A has been saved as well, just for people
Okay.
who we've learnt from previous webinars that we need
Yeah.
to save the Q&A.
Yep. Because this webinar was actually oversubscribed. We hit 500 and that's the maximum. So some of your colleagues weren't able to register. So if you can let them know that it's been recorded and be up on the college website. Thank you.
Wonderful, thanks.
See you later.